Mr. Arya for his very interesting talk on faking lenses. So he'll be talking about this another way of correcting the refractive errors of the eye.
Good morning, everyone. So I'm going to speak on topic Phakic IOLs. So this is very important topic because nowadays everyone wants to be emmetropic. So patient don't want to wear any glasses. So there are so many options for correction of refractive errors. So like LASIK is one of them. But there are situations where you are not going to get full correction even by laser refractive surgeries. So these phakic intraocular lenses, they are very, very important. So earlier there were other types of lenses which have been discarded now because of so many complications like angle spotted, then iris fixated. So these have been discarded nowadays, nobody uses them. So there are now newer innovations which are very safe and very effective for correction of refractive errors. So if we see the history, it has been long back that these lenses were started, like in the 1980s they were discovered, then in 1993 they were first started. Then because of innovation further they kept on developing, and now we have got the best type of phakic IOLs. So one of the best lens which is being used nowadays most commonly, that material in the lens is ICL, that is implantable collamer lens. So it is FDA approved also. So what is the main advantage of these phakic IOLs? So what is special about these things? So most important thing is accommodation is preserved, because we are not doing anything, we are just implanting another lens over the crystalline lens. So that's why whatever normal lens does, so that is still happening. So there is no problem to accommodation. Then corneal tissue we are not touching at all in this situation. So cornea remains perfectly normal. So even if there is a thin cornea, so there is no problem. So corneal asphericity, again it will be maintained because you are not doing anything to the cornea. Then better contrast sensitivity is there with this. Then it is a reversible procedure, because that's a good advantage. Suppose there is some under or over correction and you want to do further correction, then you can remove and then implant another lens. So that's the beauty of these things. Then there are less higher order type of aberrations in these types of cases. So why patients are interested nowadays in these? Even sometimes patient want to have phakic IOL where even the LASIK also may be possible, because these lenses they give very good high quality of vision. And then we can treat all types of patients like myopia, hypermetropia, astigmatism, and even keratoconus also. And definitely we need very small incision where there is hardly any astigmatism, and nothing is visible to the patient or to the observer because it is inside the eye, that also in the posterior chamber. And recovery is very fast, just like in phaco. So you are just putting lens, and there is in phaco still there is some inflammation. But in these patients we are just implanting lens, so very quick procedure, so without producing any post-operative inflammation. So that's why these are very, very required nowadays by the patients. So indications basically will be like very high myopia. So as I said, nowadays even where LASIK is possible, there also people are preferring these lenses because these are very safe lenses. So even so we can't say that where LASIK is contraindicated, only there you can go for phakic. So you can go for any types of patient these phakic IOLs. So up to 3 to 20 diopter myopia that can be corrected by these types of lenses. Then even toric lenses they are available, so they can correct even up to +1 to +6 cylindrical power also. So hypermetropia, that also can be corrected. So there is a wide range of correction by these lenses. So what are the prerequisites before going for these types of surgery? So that is the most important, because if you want, it is a cosmetic surgery. So if you want complication free, then we must follow all these guidelines. So one thing is age, that is very important. Usually 18 to 45, that is the safest. We can go below and above that also occasionally, but there has to be some particular situation where we can go for that. Otherwise this is the ideal situation. Then most important thing is the anterior chamber depth, because you are going to put it in the posterior chambers. Because of that, iris may be pushed forward. So if the anterior chamber depth is less than 2.8, so then we should never go for these types of lenses. So that is the most important thing, that anterior chamber depth has to be more than 2.8 millimeter. Then of course for any refractive error, the refraction has to be stable. If it is a progressive refractive error, then you are not going to achieve your emmetropic target. So again, patient will have to use glasses. Then any ocular pathology like cataract, glaucoma, and ileal pathology, so these have to be excluded first. Then if the residual bed, like it is less than 250 microns, in this situation where the LASIK is not possible, so one can go for these types of surgery, so that is not a problem. So then mesopic people or dry eye where LASIK is contraindicated, so there this surgery will be very useful. Even in excessive steep and the flatter cornea where we will not go for LASIK, so there it will be possible. So basically if we say contraindication, so these are the contraindication where I will not go for phakic intraocular lenses. So one will be a THMA depth, second will be low cell count because you are putting the lens. So again it is not that definitely less than 2000 we should not go, so one can go, but again these are the ideal situation where one should try to follow. Then pupil size, if it is larger than 6 millimeter, then there can be problem. Then early cataractus changes, sometimes if these are already there, so then better not to go, because patient may presume that because of this lens this thing has happened. Otherwise per se this lens doesn't produce any cataractus changes if used properly with all proper guidelines. Whenever there is irregular corneal topography, this lens is not going to help. Then again, like for any refractive surgeries, any retinal pathology, that must be excluded. Otherwise patient may develop some other retinal problem which may be due to retinal issue, not because of this. Then all myopic degenerative changes and age factor already discussed. And the patient having unrealistic expectations, that is also very important. So we may not give 100% correction. So patient should be always told for any refractive surgery that you may not achieve 6/6, that may be the possibility. So there are different types of lenses. So one of the most common lens and most you can say earliest lens being used, that is the star surgical implantable polymer lens. So that is nowadays there are Indian lenses also available. They are also quite safe, but this is the most commonly and you can say most longest follow-up by these lenses is there, and that suggests these are quite safe. And the material them is in these lenses is this collagen with hydroxyethyl methacrylate and hydrophilic copolymer. So this is very good material because there is a fibronectin layer over that which inhibits deposition of the other protein. So there is no protein deposition over the lens surface. It remains crystal clear, transparent, and it is doesn't act as a foreign body because it's a biocompatible material. So that's why there is hardly any side effect because of these lenses. So there are different you can say models or the designs over the time they have developed. So out of them now the latest is V4C ICL, where there is a central hole. So because of this central hole, now these lenses are very safe because you do not require any peripheral iridectomy. There is no pain, no post-operative raise, intraocular pressure because of this hole. So this latest model, that is very safe and very good model. So care group, like yesterday you must have seen in the workshop on the hands-on, these lenses, these are available outside, so you can see these lenses. So these are very good Indian lenses. So they are also quite safe, so there is no problem with these lenses. So one can use these lenses, and almost all types of refractive error they can be corrected by this care group IPCL also. So name of this lens is IPCL, implantable phakic contact lens, and ICL is by Star Surgical. Even Appa Swami, they are also manufacturing these lenses, and they are also being used quite commonly nowadays, and they are also quite safe. So there is another ICL phakic lens also by Biotech. So we have almost 4 or 5 types of lenses available in the market. So any of these lenses one can use. So there is no problem to any of these lenses. So pre-operative most important thing should be proper refraction. That should be cycloplegic refraction, so that you have accurate everything measurement. Then another parameter like pentacam, keratometry. Then of course white to white measurement is the most important for these lenses. And then posterior segment evaluation for retinal pathology and endothelial cell count, as already told. So white to white diameter, that will tell the size of the lens. So whatever size we are using, so you have to send this white to white diameter to the company, and then they will provide you this lens based on our these parameters. So like there are so many methods for measurement of white to white, but this digital caliper, that is the best and the ideal, because that gives quite accurate reading. So very simple equipment that is lying outside also. If you want to see that, you can see also. So this digital caliper, you just measure it, and that gives very accurate reading, and companies, in fact, they are manufacturing on the basis of this digital reading. So that's why that will be preferred in all the patients. So if you are using toric lens, then of course you must do this toric marking also, just like you do for toric IOL also. So same thing, it is nothing special. Same thing what we do in cataract surgery, toric lens, similarly for toric ICL also we can do this marking. So these are the various sheets. So we send the parameter to the company, then they provide the sheet and the lens. So where all the parameters are written, basically what is the post-op residual refraction, it will be there or it will not be there. So everything mentioned, what are the type of the lens, what is the axis where you have to go. So all these things are mentioned on this chart. So similarly ICL, they also provide this their sheet. So just very small videos like IPCL. So basically what you have to make 2 side port incision, very simple surgery, 2 side port incision, then 1 main port incision, then put viscoelastic substance. Then this is the loading of the lens. This is the IPCL. So IPCL loading is just like any cataractous lens. So whatever we are doing phaco, same, there is no problem. So only thing is while you are inserting the lens, so you should be very careful that you should be away from the cornea, so that AC should be deep, you should not touch the cornea. Then other thing is these 2 holes, they should be on the superior surface, that is on the 12 o'clock in IPCL. So that is the thing, otherwise it may be reverse lens. Then after that there is central hole, so through that central hole you can just press this area through the irrigation port, whatever visco is lying, so that will come from the sides, and then that can be nicely aspirated. At that of the surgery we can just put pilocarpine when the whole of the methyl cellulose have been aspirated. Then just hydrate the port, so then thing is finished. So very simple surgery. Only thing one has to be very careful. You have to take care of lens and you have to take care of cornea, because space is less. So you should be very, very careful, and it should open very gently without producing any jugs. So in ICL also all the steps are same. Only thing is loading of the lens is bit complicated and difficult also for the beginner. So once you see these things, then only you can remember, otherwise in the video it is very difficult to make you understand of loading of this ICL. So it will be little bit complicated. So after that is done, then you can implant the lens, same thing. So here the leading part of the haptic, that should have hole on the right side, that is the only thing. And all these lenses, they are implanted from the temporal side. So usually we will never implant these lenses from the 12 o'clock position. So always have temporal incision. From the temporal incision you are going to implant all these lenses. Then thorough irrigation, that is the most important. So post-operative, nothing special is required, just like for any cataract surgery. There is hardly any inflammation. You can just use topical steroid, antibiotic drops, and anti-inflammatory for 1 month to 6 weeks. Usually within 2 weeks all the inflammation is gone. So very low potency steroid can be used for these types of patients. So post-operative, most important thing is measurement of the vault. So how to see the vault? So you can see, this is the vault. We are seeing this is the lens surface. Over that, this is the gap between the lens surface and the posterior part of the lens. So that is called as the vault. So this vault has to be minimum 250 micron. So ideal is 500 to 750 micron. So it should never be less than 250 micron. So how can you see whether it's 250 or not? So one very simple way is see on the slit lamp. So corneal thickness is 500 micron. So you compare this vault, this gap between the lens and the anterior surface of the lens and the posterior part of the lens. If this thickness is less than cornea, that means it is less than 500 micron. So that is not a good thing. So at least if you want 250, so half of the corneal thickness will be 250. So it should never be less than half the thickness of the cornea. So you are seeing both the things, cornea on the slit and this gap on the slit. So just compare 2 things. So immediately you can know how much it is. So if it is almost as thick as the corneal thickness, as gap is almost equal to the corneal thickness, it means it is almost around 500 micron. So that is the ideal. So it should not be more than 750, not less than 250. Between 250 and 750, that is okay. So there is no problem. So no need to do any further intervention. So that is the most important thing one should see vault at all follow. If you have got anterior segment OCT, then you can exactly measure how much this vault is there, so that you can exactly see how much in micron it is there. So complication is a very big topic, but usually practically there are hardly any complication. The most important thing is glaucoma. So with newer innovation where there is central hole, So there is hardly any chance of glaucoma in most of the patients. So other thing is cataractous lens, which has been seen that after even 20 years of follow-up, so there is hardly any cataract because of these lenses. Only on the periphery sometimes it can happen, which doesn't cause any visual complication. So these are pretty safe lenses. So other like pigment dispersion or reshuffling that can happen if the anti-age are very shallow. So if you see all proper precautions and follow all guidelines what they have tell for implanting these lenses, then usually they are pretty safe, especially the newer designs of the lenses, they are very safe. So we don't find any complications. So whatever complications are there, if we have not seen or we have not done pre-operative workup properly, only then there are chances of complication. Otherwise, other thing can be residual refractive error that of course can be there. So for that you have to have accurate measurement. So if the lens size is small, then there will be chance of cataract. If lens size is bigger, then there will be chance of glaucoma because vault will increase. So these are the two things, proper sizing. So for that, accurate digital caliper should tell white measurement, then proper this biobit, proper this reflection and proper keratometry. So if you have got this pentacam and proper reflection done, digital caliper, so there is hardly any chance of complication. Okay, thank you very much.